My name is Noeleen Harpur. I'm the Deputy Midwife Manager at Sims IVF in Clonskee. I've worked in fertility and with Sims Clinic since 2019. To give you a little information about Sims Clinic, it's the oldest fertility clinic in Ireland and it opened in 1997. It has a total of 6 clinics across the country, 3 main clinics which are based in Clonskee and Swords and 1 in Cork. And that is where we would do scans, bloods and all our theatre procedures. And then we have 3 satellite clinics, which are located in Carlow, Dundalk, and Limerick, which are for scans and bloods. And we're also opening a new satellite clinic in Wexford Town next month as well. So that'll be added to the gang. So I'm here to talk to you about all things fertility. This presentation will include information on infertility causes, investigations, treatments patients go through, or medications that we use, and the impact of fertility treatment on individuals and couples. So what is infertility? The definition, as you can see here, is not being able to conceive after 1 year of trying if the female is less than 35 years old, and after 6 months if she is over 35 years old. It occurs in 1 in 5 couples, and it's divided into primary and secondary infertility. Primary infertility is when a pregnancy has never been achieved. Secondary infertility then is when at least 1 pregnancy has been achieved prior, and they haven't been able to conceive again since. So there are many causes of infertility, and some cases we never find a reason, it's unknown. So 3 factors that lead to a pregnancy are the egg. So an issue that can happen with the egg is that's egg quality or quantity. Egg quality does deteriorate with age, so we know that. There also the amount of eggs deteriorates with age as well as the quality. We also can have issues with the sperm. So that can be with the sperm count, with how the sperm move, their motility, and with kind of how they are looking, their morphology. And the environment then can cause an issue too, such as the uterine cavity where the pregnancy would implant and grow. We can have fibroids and polyps, which are kind of benign growths in the uterus, or we can have things like endometriosis, and those factors contribute to infertility as well. Sometimes you may have issues with the fallopian tubes. Both fallopian tubes need to be present, and both of them need to be open to ensure that when the egg is released from the ovary, it can travel down the fallopian tube to meet the sperm, and then the embryo can travel down into the uterus to implant. So we've all heard the term biological clock. We do find our patients feel under pressure to get pregnant in the peak of their younger years. It's something we're all well aware of, I'm sure. Unfortunately, age does matter in fertility. As I mentioned before, both supply and quality of eggs deteriorates with age. In a physiological way, it's completely out of our control, and so it'll happen whether we like it or not. But on the other hand, it is something that we kind of like to take control of, and we would recommend that people take action sooner rather than later if they are wanting to get pregnant. So here's a pie chart with a breakdown of the causes of infertility. Infertility is often seen as a women's problem, kind of historically, but you'll see here the percentage of fertility issues for men and women are actually even at approximately 30% each. Interestingly, about 25% of infertility is an unknown cause. That's where the results of all the investigations, I guess, come back as normal. And we don't know why this person or couple is not getting pregnant. Some people might feel like that's a relief, they don't have anything wrong, but it can also be really frustrating not to have an answer, not to have something to, I suppose, to kind of work on and fix. Men and women combined then account for 10% of the causes of infertility, and 5% fall under the category of other. So next we'll talk about investigations that our patients go through. So firstly, male investigations, you can see the statistics here on the slide. So the first test that a man would have done when he comes in is a semen analysis. So he comes into our clinic, produces a semen sample, and then our embryology and andrology team test it to check out the numbers of sperm, how the sperm move, and how the sperm look. So you can see here what is abnormal. If the numbers are less than 20 million per mil, it's too low. If the numbers are less than 40% or 40% of the sperm are motile, then it's a steno. And then if there's less than 5% of sperm that look normal, that's also abnormal. And then on to female investigations, we have many things that we do. So first of all, there's blood tests, which I'll talk about later. We can do scans, like such as an antral follicle count scan, which we do at the start of a woman's menstrual cycle to see how many follicles that she has in her ovaries. So in a natural cycle, one of those follicles will grow and ovulate, but there will be other little follicles sitting there, and that gives an idea as well of her fertility status. And we can also do some testing to check if the fallopian tubes are open and to put some saline into the uterus and do a scan at the same time to make sure there's no fibroids or polyps or anything like that in the uterus that could implant or could prevent an embryo from implanting. So one of the biggest investigations we do in terms of blood tests, and probably what a lot of people would have heard of, is your ovarian reserve, which is your AMH level. So that stands for anti-Müllerian hormone, and it's a protein that's secreted by the ovaries. As you can see from this graph here, on the bottom horizontal line, you have the age of the woman. And then on the vertical line there, you have the kind of normal percentages. And you can see that's declining as women age. The amount of eggs they have declines. So the red represents the low ovarian reserve. The orange area represents kind of a normal reserve, and then the green is likely reflective that they have too many eggs, which is polycystic ovarian syndrome. Okay. So then about the blood tests, we spoke about the AMH already. Other blood tests that we do is thyroid function, a full blood count just to make sure that white cells, platelets, iron levels are all normal. We do FSH, LH, estrogen, and progesterone bloods. So these are all cycle hormones, and it gives us an idea of if the woman's cycle is normal and if they're ovulating normally every month. And we also check testosterone levels in females, because that will tell us if their testosterone level is normal, it is indicative of kind of healthy eggs, and if it was low, they might not have as good egg quality, so they can actually go on to DHEA supplements and all if their testosterone is low. We check rubella status, which is German measles, and that's just if our patients do fall pregnant, and we need to know they're immune to rubella, as it can cause issues in the fetus if they catch German measles during pregnancy. And another blood test we do in certain patients is karyotyping to check their chromosomes. Then this is just more information on the antral follicle count scan that I was talking about earlier. Assesses the number of follicles on the ovaries. If the antral follicle count is normal, then great, happy days. If it is low, we would recommend to seek advice from a fertility consultant. And if it is high, then it can be a characteristic of polycystic ovarian syndrome. So an antral follicle count of at least 12 follicles on each ovary is an indicator that the patient may have PCOS. So it's a very important test that we do. And then just about the SIS, or high COSI. So I kind of briefly touched on this earlier. You can see in the images here, in the center of the image, there is some saline that we have introduced into the uterus to make sure that the cavity of the uterus is clear and there's nothing there that can kind of prevent an embryo from implanting. And in the second image below, this is actually an image of a fallopian tube where that bright white line is. That is a special foam that we put in through the cervix. It goes through the uterus and then goes through the fallopian tubes, and we can see it very bright on the scan. So if it flows through and out into the pelvis, we know then that that tube is actually open and clear. So some of the treatments then that our patients will go through, there's quite a few different options. So we have ovulation induction, or time sexual intercourse. We have IUI, which is intrauterine insemination. We have your standard IVF, or ICSI, which is kind of, I suppose, more advanced form of IVF. In IVF, they mix the eggs and the sperm in a petri dish and let them fertilize themselves. With ICSI, they will actually take a sperm and inject it into the egg. So it says here plus or minus PGT. which stands for pre-implantation genetic testing. And that is where they will fertilize the eggs with the sperm, grow the embryos into blastocyst stage on day 5 or 6 of development, and then they'll take a little biopsy from the back of the embryo where the placenta would normally form, and that little biopsy sample is sent off externally for genetic testing to make sure the embryo is a normal embryo. We find women with multiple miscarriages often go for this test, or if they're over 40, because they're more likely to have chromosomal issues in the fetus, and that's why they may have miscarried. Or if they're over 40, they're just more likely to carry a baby with chromosomal issues. And then we have our egg freezing, which is a very popular option now. And egg donation as well has been popular with us for patients who have either a low ovarian reserve where restrictor AMH is very low, or older patients as well, kind of over 42. And then we use donor sperm in our clinic too for heterosexual couples, as well as same-sex female couples and single ladies as well that are coming through to us. And then we do a shared motherhood cycle as well for same-sex female couples. This is where one of the women will have a egg collection, and then she will donate her eggs to her partner. They'll be fertilized with donor sperm, and the embryos will then be implanted into the partner. So it's actually a very nice option. Both of them have a part in developing the pregnancy. So IVF or ICSI are most common treatment type that we see, probably one you've heard of the most. Has the best success rates, and kind of the women tend to get pregnant quicker, and instead of going on through multiple treatments of an intrauterine insemination or something like that. We also find that if they do IVF or ICSI cycle and they have extra embryos left over, then these are frozen for future use, saving them kind of coming back in for another egg collection and invasive procedures. And the diagnostic benefit of it there is that we also get to find out from this what the embryo's quality is like. The embryologists look at the embryo as it's developing, and they grade it, and we can see if they're good quality embryos. So here is how the IVF cycles work. You can see here in step 1, the egg production is stimulated by hormone therapy. So this will be in the form of FSH or LH injections, sometimes a combination of both, such as Gonal-F or Pergoveris. So the woman will start out by taking these injections every evening, and they will grow all the little follicles that are sitting there to start a cycle. And we'll scan the woman a few times and take bloods to make sure her hormones are okay. And then eventually, when her body is ready, she'll be booked in for an egg retrieval, which is step 2. So during this step, then they come in for a procedure in our clinic, and they actually drain all the follicles of the fluid, and then the embryologist checks through the fluid for the eggs. This is done under IV sedation normally, and takes about 20 to 30 minutes, quite quick. So while the woman is in theatre, then number 3 here, you see a sperm sample is provided. So either we'll have frozen donor sperm on site, or if there's a male partner, he will go in and give a semen sample and hand it to the lab. Then the eggs and sperm are combined to allow fertilization. And then they are developing into embryos all the way to step 5. And then the embryos are introduced into the uterus during an embryo transfer procedure. So for IVF cycles, the protocols that we tend to use, there's a few different ones that our doctors use. So it's individualized to each patient. So the doctors look at their history, see what kind of cycles they've done before. If they need to change up any protocols or medications to try and get a better response, they will do that as well. So we have short cycles, long cycles, and then at the end there we have a cap cycle if they have a history of a poor response. We'll go into that in more detail anyway later on. So for a short antagonist cycle, the woman comes in for multiple scans and bloods. She will start on medications at the start of her menstrual cycle. So we have Gonalep and Luverus there now. I do know Luverus has been out of stock for a little while. So most commonly now we're actually using Gonalep, Pergovirus, or Recavel. So they'll take these injections for 10 to 14 days every evening. They'll introduce this cetrotide injection after about 5 days of taking the stim injections. What the cetrotide does then is it suppresses their LH to stop them from ovulating too early before their egg collection, because we don't want them to ovulate beforehand because we'll lose all the eggs. And the cetrotide will continue up until 2 days before the egg retrieval, where they take a trigger injection. So the trigger injection is usually Ovitrel or Buserelin, or both. Sometimes we also use Ganassi. And what that does is it gives the eggs the final maturation before they come in for their egg retrieval. And they take this trigger injection 36 hours before the egg retrieval is booked in. As you can see there, the egg collection then will happen about 36 hours later. So all of our prescriptions, they are created electronically. We'll also have a high-tech hub number, which we will put in the remarks on our prescriptions. And then we either send to our nominated pharmacies or local pharmacies, always via health mail address. So there's various different medications that may be sent to the pharmacy. There's down-regulation medications, such as the Buserelin I mentioned before, or Prosap is another one. There's stim medications, which are the Gonalep, the Recavel, the Pergovirus, or as I said, Luverus, but that's out of stock at the moment. And then actually I'm going to go into this next slide because it kind of explains it better. The ovulation prevention medications then are either cetrotide or Buserelin, once again, it's a popular one, or sometimes Cineral nasal spray can be used as well, but we don't use that often. And then our trigger injections, as I said, are Ovitrel, Buserelin, or Ganassi. And as I said, they're for final maturation of the eggs before the egg retrieval, and then they're designed to cause you to kind of time everything for your egg retrieval. So other medications that they'll start after egg retrieval are progesterone support. This is to prepare the body for pregnancy. So they start these normally 5 days before their embryo transfer. And the most common ones that you'll see are Crinone gel, which is a vaginal progesterone gel that you insert morning and evening. We also commonly prescribe Prolitex injections, which is subcutaneous injection of progesterone that we usually prescribe as once a day. Cyclogest, very similar to Crinone gel, is vaginal, and morning and evening is when our patients usually take it. Same for Deuterogestin, it's vaginal too. And then kind of rarely enough, we would prescribe the progesterone in oil, which is an IM injection, and it's not very pleasant for patients to take, which is why we don't use it very often. For pregnancy support then as well, sometimes our consultants might prescribe Clexane or aspirin throughout the cycle that will continue on through pregnancy. If the cycle works. Sometimes we prescribe steroids as an immunosuppressant, and then we'd usually have vitamin D, vitamin B, and folic acid on our prescriptions as well. So this here is an example of a kind of common prescription you would get from Sims. You'll see the vitamins on it, and we have a bit of paracetamol on it for around time of egg retrieval for pain relief. We usually have doxycycline there, bimycin, and that is prophylactic around time of egg retrieval as well. And Solpadol for pain relief after egg retrieval. And then we have our stim injections here, Gonalep, Luverus, and our suppressant cetrotide. We have our Ovitrel trigger injection, and we have some progesterone support then. And sometimes we do prescribe the pill to then regulate a woman before she starts her cycle. Another common thing we do before she starts is prescribe actually Estrofem or Femitab. Is something that we're using a lot recently. So in regards to storing medications, this is a question we get asked a lot. So medications that need to be kept in the fridge are the Gonalep, Pergovirus, cetrotide, and Ovitrel. Room temperature then, as I said, we have Luverus there, but we're not using that as much. And the progesterone medications and the supplements are all room temperature. We've talked about the supplements there already. The blood thinners, then as I said, we use Clexane or aspirin. Our women are on those quite a lot, actually. You'd usually see them on our prescriptions, and then immunosuppressors such as prednisolone. We have our antibiotics, doxycycline or bimycin, and then our painkillers, as I spoke about. And yes, other things that you might see are Yasmin, the pill, Provera to induce a bleed if the woman doesn't get regular bleeds and we need to kind of schedule in her cycle. We'll have a lot of women on allotroxin if their thyroid has come back high in their initial blood results. We use CoQ10 as well quite often for egg quality, just to improve egg quality. Dosinex can be used sometimes if their prolactin levels come back as high, and DHEA if their testosterone levels are low. Same there for the Testagel if their testosterone levels are low. And we'd often use metformin as well. So we use all sorts of needles or prescribe all sorts of needles. So the mixing and injecting are always the 21 gauge and the 25 gauge. Decapeptyl, I hadn't mentioned that yet, but that is another trigger injection that we sometimes prescribe, usually from our core clinic. So same there for the mixing and injecting in terms of the size of the needle. For the buserelin, we would usually now prescribe the 1 ml insulin syringe for this. And they'll either take a 0.5 ml or a 1 ml dose of the buserelin injection. And then progesterone oil, if they are using it, 21 gauge for mixing and 23 gauge for injecting. So common advice then that we give for our patients is to be, I suppose, the healthiest version of yourself. It's better to address any health issues prior to fertility treatment, and where possible to remove any risk factors for fertility treatment or for pregnancy. As healthcare professionals and fertility specialists, we recommend no smoking, minimal to no alcohol, definitely less than 3 units per week. Reduce caffeine intake to 200 milligrams per day or 2 small coffees. Lower kind of impact exercise is another thing that we say, especially once they've had their embryo transfer and they could be pregnant. We advise them to stop any kind of HIIT or spin classes or anything that's a high impact exercise. Sometimes as well, we do advise them to stop that during their IVF cycle when they're on stimulating injections, because their ovaries get quite swollen with all the follicles growing within them. And there is a risk of one of them twisting and torsion. So we would advise them just to have gentle exercise when they're on stim injections as well. Obviously a balanced diet, as we all know, and we would recommend fertility supplements such as the folic acid, the vitamin B and the vitamin D, or something like ProSieve. So just a little bit of advice for pharmacists, I guess. A lot of patients ask about the side effects of the medications. Usually the main side effects I would talk about would be while they're on, it's more of a physical thing, but while they're on stim injections, they can get quite bloated, especially as they're coming closer to their egg retrieval. Once again, because the ovaries are quite swollen and quite large, so they can get quite bloated and uncomfortable. That's a common thing that they might say. They can get quite tired while they're on the injections, complain of like being very, very tired, probably psychological as well as a kind of physical thing. After the cetrotide injections, they can get a little kind of red raised area and a bump that should go down after, well, it should go down by 4 hours kind of after taking the injection, definitely. It's usually a bit quicker than that. Our patients are very, very overwhelmed and anxious when they're collecting their meds. I know when they collect them, they usually get about 2 big bags full of medications, and it's a lot for them, especially if they've never kind of taken medications before, which a lot of them haven't. So they do tend to have a lot of questions, and they get quite caught up about whether they are to be in the fridge or not in the fridge. So it's always good to mark which ones are fridge items and which aren't. And any kind of queries that either the patients have or that you have yourselves as pharmacists, you can always contact Sims. We get pharmacy queries quite a lot, and we bring you back and just answer whatever questions you have. Then just to talk a little bit about the impact of fertility treatment. So it's a very, very hard thing for our patients to go through. They go through the procedures and the injections, and that's kind of tough enough, but it's normally the waiting that the patients talk about is the hardest part. Like waiting for their pregnancy blood test, waiting even at the start to see how many follicles they have, how many eggs they might get, and then at the egg retrieval, how many how many eggs were actually mature and were fertilized well, and how many embryos they got in the end. It's really, really tough, and they just don't know what to expect. Um, so each phase, I suppose, is a milestone for them. If they get those follicles, that's great. And then if they get the amount of eggs they think, then that's even better. If they get a good fertilization rate, embryos, all very good. And of course, what we're aiming for is pregnancy, which is the loveliest part of it. But then there's another big wait for them even after that, when we have to bring them in for their early pregnancy scan, and they're hoping then that that's obviously going to be okay as well. And it's a very anxious time for them. It's a huge financial burden as well. Like the treatments can cost thousands. Thankfully, the medications with the drug payment scheme card are capped, but the treatments themselves in fertility clinics they're quite expensive. We do home payments, and we do work with different people who can kind of like, such as Access Fertility, who the patient would pay a certain amount to, and if they don't get a baby at the end of it, they get refunded. So there is different things out there, but it is a big financial burden all the same. And it's a huge physical burden as well. Like, emotionally, it's very, very tough for our patients. And socially is a really big one to talk about, because a lot of our patients actually feel a stigma to do with fertility treatment, and they don't talk about it to family or friends. And another big thing is they don't tell their work, and they're coming in for all these scans and bloods within the space of 2 weeks, and trying to either get in early before work, or tell work that they have last minute appointments. And so it can be really hard and really, really isolating for them. In Sims, we do 7 a.m. scans in some of our clinics and blood appointments, so it can be really helpful for them to pop in early and then go to work afterwards, so they don't need to kind of face that burden as well as everything else. So, as it says at the end, understanding and sensitivity is required at all times.